Welcome back, everyone, to the Functional Code. We are excited to bring you guys today a new core episode. This is where we dive into one of our previous podcasts, and we just bring out the essentials, the gems, what we think you guys wanted to learn from that episode. And so today, we are going to be diving into the ball and socket joints, the shoulders and the hips. Going to be talking all about that, how to improve them, how to help them, and what you can do for optimal longevity. As always, I am Dr. Addy.
And I am Dr. Jace. So yeah, with the hips and shoulders, there's a lot of movement that can take place.
Yes.
If you don't have a lot of movement, there, for most people, is a lot of potential. One, increase range of motion, then two, ease up some of the compensations from the shoulders inwards or even outwards. So meaning compensations from your shoulder to your down to your arm, or your shoulder to your spine, upper back, mid back, or most commonly hips and lower back and that type of compensation. We'll get into some of that here in a hot sec, but Doc, we talked about this prior to this pod, the shoulder being the most movable joint. Do you want to touch on that?
Yeah, I think most people, when they don't understand joints to the point of maybe to the true anatomy. So when you have a ball and socket joint like the shoulder, you need to understand that with its ability to move how it can move, it does give it the ability to be the most vulnerable because it has so much ability to move. Now, when we have a breakdown in the body tissue-wise or some type of injury, the impact that it can have on this joint can be really immense. Now, I know this because when I injured my shoulder, I broke 2 bones, tore 3 or 4 tissues, tore a ligament. I messed this thing up. And I lost the ability to move this shoulder for at least 6-ish months.
Wow.
And it took a lot of time to, my guess, heal the tissues that needed to be healed, but also retrain and recondition the tissues that broke down in that time because I wasn't moving it. I wasn't moving it appropriately. So when Doc said there is potential, there absolutely is potential. And you can absolutely train to improve that range of motion, get that back. The body is an incredible being. And so if you're dealing with shoulder pain and hip pain, stay tuned because there are plenty of things that we can do to bring that range of motion back and that strength back.
Absolutely. And when you look at, just even starting with the shoulder, there's the whole shoulder blade itself. There's a humerus or your upper arm bone. There's the collarbone. So there's a lot of pulling mechanisms involved. There's a lot of deep structures. There's a lot of overlying muscle structures, as you can see kind of from the video behind us if you guys are watching. So when you're looking at all these in itself, again, going back to some of the other podcasts as we talked about this exact same point, the nervous system communicates to the joint first. And if there's any problem with the joint, it causes overlying muscle guarding compensation tightness, if we will. So if we start at the rehab structure deeper, it opens up the potential from there. Now, there's other things that can go on in terms of conditions of arthritis, of past rotator cuff injuries, of tears, breaks, like Doc said. So that also has to be rehabbed and trained, each condition in a specific way. And then there, you can open up things from there. But just a little bit decent understanding of how we can go about opening things up on that side of things. In terms of movement potential, you're going to need to move your shoulder blade on top of your rib cage. You're going to need to move your shoulder blade different from your upper arm bone. You're going to need to move your collarbone different from your shoulder blade and different from your ball and socket joint.
Yes.
So all that has to be very specific. And that's where, if you're going to find someone that knows how to do that, I think in general speaking, if you can find a functional range conditioning specialist or practitioner, that's a good place to start. There's others, especially PTs most commonly, and a couple chiros here and there that knows what's going on, but those would be the places to start from there. So Doc, actually this is fun. Thank you, ChatGPT. They put together mainly for the hip, but there's a lot of principles involved with this. It's called the Capsule code. So we're gonna break down each and every letter, starting with C and all the way through E, on different types of mechanisms and how that interferes and applies to the hips and shoulders. So C, capsule, is the interface. So Doc, going back to the point that we made up, it's not just connective tissue, it's the primary joint feedback. This then comes back to the mechanoreceptors. And I know you've worked in workspaces, control articular rotations. What are certain things that you've noticed with either your range of motion when applying this or even the healing rate?
Yeah. So when Doc talks a lot about pain-free range of motion, you need to be able to move your joints into workspaces or cars and doing it in a pain-free way. Any bit of pain-free motion, I could feel just such a relief when I gave my brain that messaging, that stimulation. And so I'm trying to put myself back into what I remember feeling. But what I remember is when I couldn't move it at all, I would go into the hot tub. The heat helped a little bit more, I think, just stimulation wise, maybe getting more blood flow. But it also took gravity off of the joint, which also helped me move it a little more. So as I was doing, this was it for the first maybe 2 months. But that alone started to make a difference. It did. It really did. And it may not feel like much, but any bit of information that you can give the brain, and Doc said a word, mechanoreceptors, it's because, and proprioceptors as well, these receptors that are embedded into the joints, into the tissues around it, they provide information, and you need stimulation and movement in order to do that. So those feedback loops are critical to improve not only pain, but movement and just overall general well-being and thought of the brain towards the joint. So you need to be able to make sure that if you do have an injured joint, practicing that right away as soon as possible probably is going to be very effective. But even if this has been a long time, just to start obviously isn't going to be an issue. It can absolutely help. But really, I think the biggest thing was making sure that I didn't overdo it, and just to move where I could in and around that space until I got to a point where I could start applying some pressure and some resistance. And then, of course, we're working up our ways into different levels of workspaces. But I do remember how helpful it was, and I think a lot of patients do as well.
I love that. And a point that came up in my mind, I think, is very important, very valuable, and I may be jumping ahead here and maybe on a couple of these, is you said pain-free range of motion, or movement, if we will. So if you have pain, it depends on, is it open angle pain? So if you would look at, or if you're even just listening, the torso and core from the arm. And if I'm coming up, if I was doing any type of movement, quite frankly, but jumping jacks for this example, and how I'm moving my arm up overhead, the open angle is mainly between the torso and upper humerus arm when your arm's coming overhead, or it's closing angle pain between the upper arm and the neck. So you can see either open or close. Now, if you have pain on the close angle side, usually it's either due to lack of space, to where there's not much room in the joint capsule, or there's so much space that the body can't control it, and the pretty much the ball and socket joint is moving more than it should. It's unstable, and that causes this pinching off pain. Usually, most people, when you're going into open versus closed angle pain, there should be probably more tightness, stiffness for most people on the open angle tension, open angle pain, like a deep pull, a stretch, versus the close angle. So pay attention, close or open. Now let's say, for example, if your arm was coming across your body from outwards, inwards, to where your arm's in front of your body here, the close angle pain would be on the front side, and it could be either due to the collarbone, it could be due to the humerus, it could be a bicep tendon issue. It kind of zones in everything into that exact area, and that's where you would either want to go build up the tissues, not into that pain, but diminish the angle, and then go isometric squeezing, and then working around where that close angle pain is. And then you would need a provider to do some deep muscle work, either on the opposite side of the joint, or a stimulating phase of a pin and stretch movement, working closer to that angle pain, or that close angle pain, and then working outwards from there in multiple ranges of motion. So those are two different things I think would be very important for most people on that side of things.
So Doc, I do think this is helpful for patients, but why is having a capsule to the joint something a lot of people need to understand, like what it is? Because
Yes.
I think There's a lot of conditions that can stem from capsule issue, capsule tightness, all these things.
Yes.
What is it and why is it important?
Yeah, so that goes back to the next point of the A in capsule, the afferent pathways. This also comes down to Hilton's law to a certain extent as well, but when the joint is the first signaler to the brain, you have to look at what is going on with the joint level first. And that's where you can either go into assessment portion of as a practitioner, or let's say you're a significant other and you just want to see what's going on and differentiate, is it more a joint or is it more muscle tissue? And it could be both for most cases. One could be more of a priority than the other kind of deal. But you would want to passively or have someone else move your arm through the fullest range of motion. And if you notice that there's more range of motion from when someone else moves it versus when you actually move your arm itself, the main difference that we want to look at is if you are moving and let's say there's pain in certain areas versus someone else that doesn't, that could be either a mixture of overlying muscle sprain, strain, something going on with the connective tissue, versus let's say if they would move it and then there's limitation, or even if it's like a frozen shoulder, that would be at a deep capsule level. So if someone else moves your arm, your limb, your joint, and there's a restriction, there's pain, that is usually a joint level in the first place, and you would have to start with a joint level input, and that's where CARS control, the articular rotations, come into play. But going back to a frozen shoulder, I know we dove into this previously, but there's a huge component related to the autoimmune condition and an inflammatory response in the body, that specifically.
And it attacks the capsule.
Yes.
Yeah, for sure.
So those would be fun, small ways. And then when we go into the next letter P in the capsule, the paper mache levels, I thought this was interesting on how it builds on different layers, like the joint capsule, then to the ligaments, then to the overlying muscles.
This does have a good little bit of an underlying explanation, just all the layers that go around the joint itself. And some tissues white, some tissues red. We're talking muscle versus ligament versus tendon, all these other things too. Don't forget fascia, don't forget blood flow, those kinds of things. So yes, that tissue itself, tissues plural, and there's different ways to load those tissues. And I think we talk about that too. And you need to be able to load the capsule, the ligaments, the joints first, then maybe think about more overlying tissue, muscle, that kind of thing. So let's say patients who don't have good range of motion in their shoulder. Now, let's say they weren't able to do it themselves. Someone else took my arm and it was perfect. They put it through a full range of motion.
Yes.
But then I tried to do it and there was restriction. What does that mean for me now? What should I be focusing on?
Okay, so when you would want to break apart the difference between passive range of motion, someone moving your arm, versus active range of motion. And that's the area of potential that you could either move into. Now, let's say there's limitations with passive range of motion and someone moving your arm, that can open up to a certain extent depending on the joint level. Is it arthritic? Is there not like enough joint space? Is it too unstable to where the capsule needs to tighten up? That has to be done in a specific way. But when you start breaking apart passive to active, that comes in means of the central nervous system's communication to the body, which then goes into the space cultivation and the next letter of the capsule. And I think actually you explained this so well in terms of motor units, of how the nervous system connects to the tissues. Do you want to explain that?
When we have motor units, when you think of motor units, think of like little connections, little wirings that are from the brain to the muscle. And there are thousands, maybe even millions. I don't know how many, but I'm sure.
Probably millions.
Yeah. And think of it like this. These units all come together to tell the muscle to contract and to do its job. But let's say half of the units stopped working for some reason. So I always think of this as you have 10 friends around a fridge trying to lift up the fridge together, but 5 of them don't want to help. And so the other 5 have to do most of the work. Now, how much different would it feel if all 10 were actually lifting at the same time versus 5? This is exactly how motor units work. So if you had all million working exactly how they needed to be, you would have very little effort. You could lift so many different things. It would feel almost effortless to do. But the body doesn't work that way. It tries to conserve energy as often as it can. And so it only tries to recruit the minimum amount of units for that effort at all times. So what we have to think about is when we're having issues with active motion and probably either a deconditioned muscle that doesn't have a lot of motor unit recruitment, those kinds of things. How do we get more motor unit recruitment? How do we get more function from this? And that's where we would start conceptually.
And then it goes down to the stimulating phase, which that goes back to the intensity talk of stimulating, high intensity. You push the area, the tissue to the fullest capacity. And then there's detraining and retraining. Detraining is you're pushing in your body, but maybe not to the full capacity. And then retraining is like active recovery to a certain extent. So you want to work in a homeostatic regulation. But to increase between passive and active, you need to recruit a lot more units. So you have to get into a high and stimulating phase,
Yes.
Meaning you have to either hold an isometric contraction as close to that fullest range of motion as you possibly can, add in maybe a little rotational movement, again, stimulate that, move anywhere from 10 to 15 degree difference, same thing. So you're able to open up and address all the tissues around the joint and the whole capsule itself to increase the range of motion.
Yeah.
Going back to that point, well stated.
And I don't know how many people have ever done that. I know most, they get to the gym, they do some curls, they do some mostly stimulating thought, conceptual movements versus
Yes.
actually thinking about other helpful ways to train the tissue in the body. And so you're missing a lot is what Dr. Jace is saying. You're missing a lot of tissue. You're missing a lot of important and crucial structures to help with the stability of the joint and to help with the function. And if we have a breakdown in the joint, it probably came from the fact that you weren't focusing on this in the beginning.
Yes.
But you still have time. We still can absolutely try to figure out workspaces and isometric holds and other ways to train this tissue. It's not that it's gone. It just needs to be communicated again. It needs to be messaged. And I think the brain has just over time not received that message, unfortunately. Your muscle bellies have given good information, right? You've done plenty of curls, but Doc has explained why that's also an issue, because if you get really well-trained muscle belly, but your tendons and ligaments aren't getting trained, then we have compensatory changes too. Now you're getting a drastic pull from the muscle belly, and the tendons themselves aren't strong enough to hold. And then we get issues there, tendonitis, breakdown, all that stuff.
Yes.
Did I miss anything, Doc?
No, that was good. And that actually bleeds us into the next letter U in the word capsule of unforeseen movers. And those are usually the small stabilizer muscles and tissues that are either in the hips or shoulders. And I like this example for the shoulder specifically because a lot of people don't realize this is even a muscle in the first place. The subclavius.
Oh, yes.
So it's a small muscle that runs horizontal between the first rib and the collarbone. And that's almost a tension regulator for the whole front part of the capsule. So that is a small stabilizing tissue that has more of a communication signal aspect to it instead of on the muscle belly, instead of like a contraction relaxation. So unforeseen movers, unforeseen like stabilizing muscles are very important to build up. Also, proprioception helps with blood flow. There's a lot of other small things involved with that as well. But
I would say in the hip, a small one would be the glute medius and minimus for sure.
we'll stay.
Those are small rotators of the pelvis that really do tie into how tight the hip can be. I think another one would be the TFL, is maybe another smaller tissue that I think would be helpful as well.
Let me pull that up here.
Yeah. And so as Doc is talking, I think a lot of the times we tend to train the big movers. We tend to train the big tissues, and we forget a lot about the little tissues, and we forget just how important that they play into the function of a joint and the function of the body. So most of the time when we're in the gym, we're hitting the big guys because that's what is aesthetically pleasing, and that's what gives us the contour and shape tone that we're looking for. But over time, if you want to improve your quality of life and your function of the joint of your health, it's these tissues you have to start thinking about too.
100%. Going back to the points we've made so many times, if the muscles overpower the connective tissue, injury usually then ensues from there.
Yep.
So yes, you want to look good, feel good, grow all this muscle mass to be aesthetically pleasing to others, I'm assuming, or maybe even yourself. You're going to need these smaller tissues just as much as you're going to need the bigger tissues. So you have to take both into consideration when building everything up, which then moves into our next letter, L, in the word capsule. Ligament as a load response, and this often comes with Golgi tendon organs, which is a kind of a small, like a receptor within the tendon, and that goes to the point of putting the body under load in a specific manners. Doc, when you think about ligaments, what are some things that you think about when loading and how it loads?
I think about people that have connective tissue disorders, those that have ligament laxity, or they have a lot looser, they're double jointed and they can do things that maybe their friends can't. And sometimes it's a concern condition wise, sometimes it's just women tend to have a lot more ligament laxity, but it can give them, they can be predisposed to injury if they don't have stability through that range of motion. And what I mean by that is you have the ability to maybe move outside of normal range of motions compared to other people, but do you have the ability to maintain full contraction at that end range of motion? And if you don't, what could that be if you ever got past that range of motion, outside of normal range of motion, and then had an injury because you weren't either prepared or you didn't train that way? And a lot of the times what you'll find is it was an insult or sometimes a trauma to that area that you weren't ready for or prepared for that caused this issue. And I don't know how many times we were treating patients for the Minnesota Vixen, the semi-pro football women's team.
Sure.
And I think in the first 8 weeks, there were 6 ACL tears.
Oh.
And I think it had to have been either from, and it's tough to put it all on one thing, but I do think ligament laxity, just as a woman, was a part of that. And maybe it wasn't the entirety of it because they were semi-pro, so they probably weren't training all the time. But I think there was something to be said about that.
Not 1, not 2, not 3, 6.
6 in the first 8 weeks.
There is something to be said about similar injury over a longer period of time, especially if the team in general maybe trains together in similar ways. I would go straight to the athletic performance trainer. There's something missing, whether it's the off season, whether it's in season, because there's different ways that you can rehab and prevent certain injuries.
So Doc, with the ligaments, what are some ways we can shift to training ligaments, and why is that important?
Yeah, so like you have to have the support. So ligament is bone connected to bone, and there's just a tissue involved. The tough part is with training ligaments, there's not as much blood flow with that.
Yes.
So you have to either increase the nervous system drive, which subsequently brings blood flow with it most times. So you would either want to go to the end range of motion. So for example, let's say for the shoulder AC joint specifically, for those that are not watching, you would want to bring your arm, maybe palm facing forward, as close to your side as you possibly can. So you're feeling some of the tension on the top front portion of your shoulder and then holding that isometric contraction. Or you're lengthening the joint, putting a stretch on it, and then forcing a muscle contraction around that exact area. You can maybe move in different areas and ranges around it, but you need that stretch response at the fullest range of motion. Now, the part that most people forget about or don't think about is with the ligaments, tendons to a certain extent, there has to be a recoil phase to it. So you'd want to go to the end range and add in like pulsation work with maybe an exercise band holding on your side, and you're pulsating. Another way you can go about this, maybe with hips or maybe full body, is like small jumping, working like the Z-axis for periods of time. But usually exercise bands, you go through the fullest range of motion, lengthen the tissue, and then add in small pulsations in a rotational fashion, or mixing in the range of motion a little bit, because they have to respond to recoil, and they also have to respond to the full stretch in order for them to start the healing process. Because anytime you have an injury, you have to rehab in the exact same direction in which you got injured for the exact tissues to heal in that manner.
I love that you said that because I wanted to talk to you about this because I saw Dr. Espina.
Oh yeah.
He was doing this, he called it an eccentric progressive, I can't remember what he called it, but basically he had a resistance band connected to his knee and it was off to the side and there was some slack to it and he was bringing it
Yeah.
close to him, but then he'd let the slack come out to tug his leg back towards where it was connected to, and then he caught it, and then he'd almost allow that slack to give a good tug. Yeah.
So it's almost
So was that the recoil part of it that he was doing?
Yeah, there's different ways that you can go about it, but yeah, it's more for the connective tissue to where you would activate it, and then as it's in end range, you have a stimulating or external force for the recoil, but you can almost think about it in terms of like athletic movements. So let's say a wide receiver is going up to catch a ball, he gets torqued, maybe the legs or arms get taken out in different manners as you're going through that end range. If you're not trained that recoil of trying to go up and catch a ball, but there's an external force affecting the arms, body, torso, doesn't matter where, you have to account for that. And that's where, if you don't train it, there's a higher risk of injury. So it's training that recoil work in different positions to build up the connective tissue capacity. Because you can stiffen up, like when you look at cadavers or dead bodies, if we will, you're going to see in terms of the tissues, whiter, more thicker, dense tissue versus muscles, which are like more red versus the white. And you can build the white connective tissue through pulsations, recoils, and that's what you were theoretically building up from there.
Got it.
Yeah. Good question on that one.
So the E is evolution's blueprint. Evolutionary changes, things that have become either thicker or we've grown just as being, and I know you sent me you sent me something on the fibula the other day.
Yeah.
How we used to have connection to the femur. Yeah. And then now it actually grew off and was his own space to help with, I think, stability of rotation.
Yeah, I think that was from the evolution of how the human went to bipedal, walking on 2 feet versus more like an ape-like type of movement, arms and hands working together as one. So the muscle belly, it's a small muscle called the popliteus. It went from the tibia, fibula to switching over across the plane. Here, I'll pull it up here, which I've heard about that in some of Dr. Andrew Spina's past podcasts before, but it's interesting when you actually look at it. So popliteus controls locking and unlocking the knee. So as it went from the tibia to fibula, so on the bottom 2 bones, it transitioned right above to the femur, from the inside to the outside portion, which allows rotational movement of the knee or tibial torsion. And that is a fascinating type of evolution that we've started seeing. There's other small things in terms of the hips and the shoulders and some of the small like muscles for gripping that are not really found in the wrists of most people today, but were back in the day. It's just these small changes over time which influence the capsule and how you move and function from there.
And I think as we evolve in how to train, I think thinking about the smaller tissues is going to be so much more advantageous versus hitting the big hitters, hitting the big movers. All right, Doc. So let's just take a patient and this patient really is, their issue is they haven't been doing a whole heck of a lot with their body and their shoulder. Let's just use shoulder as an example. It's a stiff and they're not able to move it as good as they used to. They have somewhat close to full range of motion, but there's a little bit of tightness at the top and they're concerned that there might be arthritis in there. And what would be some ways to, and let's say there's nothing else going on. Let's just make this as simple as possible. What would be some ways you're going to start already helping them improve that range of motion, and maybe what are some things that they need to think about moving forward?
Yeah, so when I think about the shoulder and hip is similar, any ball and socket joint needs different stimulating types of movement. And going back to how the nervous system communicates to the joint being the first line of communication, when you look at, if you're not watching the diagram above, you'll start noticing that some of the ligaments around the area that come in and attach from the shoulder blade to the humerus, so upper arm bone, in a rotational fashion. And now that comes with, and even on the bottom side here from the shoulder, that's where you want to start that first line of communication being rotational work. So I suggest this for anytime someone warms up, anytime, and this can also be as the workout itself. For the shoulder specifically, going from internal to external rotation. So bringing your palm of your hand, fist down to the ground, and then back opposite way, kind of like you would throw a baseball backwards. Doing that across your body in a horizontal plane, but then also lengthen it and go in the opposite direction overhead, rotational work, and then behind you, rotational work. So you get both, you get all the rotator cuff muscles, you get all the tissues from the torso to the body, and then you add in rotational work with the torso as you come across. Kind of mimics like forehand in tennis to backhand in tennis. So that's where you can build up those connective tissues from there. Subsequently, it'll bleed some of the energy into the ligament capsule itself, and then overlying muscle tension and tissues as well. That's where I'd start. So I'd almost start with workspaces, cars, biggest workspace you possibly can moving into, and then go into rotational work, and then go into whatever other types of tissues that you want to work on or types of movements that you want to work on, and you can be specific on how you want to warm up those muscles from there. But if you warm up the connective tissue, the joint capsule first, you're going to be seeing pretty darn good from there.
For sure. And I think a lot of people would say, okay, I have stiffness, I'm going to just stretch it, and I'm going to just do this stuff. And you notice how that was such a different way of improving the joint than what I think most people understand. So when we're talking about this, it may sound new and foreign, and it sounds like it's a lot of work, or well, really, we haven't even got into the more advanced ways to, we want to help patients too. Once we get to a full working joint, how do we put muscle on? How do we make you, like, we haven't even got there yet. We're not talking about going to the gym 6 days a week, lifting a lot of weights here. We're just trying to get you to feel better. And so I don't want you to think of this as foreign or to be confused as a lot of effort and max effort and all these things. We're really just trying to get you guys to improve the range of motion that you have and get you to a point that you maybe can then go back into the gym and be more effective at lifting weights and having a lot less pain overall.
Essentially, it's creating a huge foundation, or a bigger foundation to where you can grow on these different pyramids or these different building structures on top of your foundation, top of your land, if we will. So yeah, I love that point, because most people, they know how to work out to a certain extent, but it's these other small things that are so important that will help prevent injuries for most people and then build up from there.
The only thing I have to add, because that was perfect, is even some slight cardio before to get the blood flowing. I love that. So with, excuse me, with shoulder work, that I do a 15-minute walk, and then I do exactly what you did.
Oh, sweet.
And then I'm ready to work out. For some people, just do that. And then you don't even have to work out. It just, that alone is foundational enough to keep the joints healthy, feeling good. And that can be considered something very light, a light day in the gym.
100%. There's 4 main ways that you can go into strength training. It's either going to be 1 rep max, 3 rep max, till like pretty much as under load or highest resistance possible. The next one is going to be moving a weight at the highest speed you possibly can, or your body at the highest speed it possibly can. The next is going to be time under tension till failure, to where maybe you're moving a light resistance or your continuous movement, and you're doing 1 rep and you can't move anymore. And then the other one, the last one, is going to be, you're going to be moving a body weight maybe against resistance, but not till failure. And so you can pick and choose where you want to use some of these, whether it's small connective tissue, whether it's joint capsules, whether it's the muscle belly, and actually like the standardized thinking of bicep curls, lat pull downs, like bench press, all that stuff. So you can see how things gel together. I think one thing specifically for the shoulder that I think can help a lot of people is the scapulo-thoracic rhythm. So it's pretty much between the shoulder blade and the torso. Now, if you want to fix a scapular wane or steps to help the scapular waning, you're going to need movement into that range of motion. So it'd be a scapular workspace, scapular cars, moving down, moving your shoulder blade together and down, and maybe holding that there for longer periods of time. Trying to go for a walk and move around while it's held in that same position while moving your arms. It retrains the muscle memory to a certain extent, but you need longer periods of time with your shoulder blade in that specific range of motion, that specific spot. And then that can be pretty much a whole catalyst to build it up from there.
Yeah. And I think a lot of
Small thing
people
there, but
have scapular winging, and that is a part to why they have shoulder pain. And I think a lot of the times they don't understand that it is something that can be an issue.
yes.
Maybe earlier on, they're like, oh, look what I can do. Look at for what we're talking about is it's when some of you have the ability to jut your scapula backwards and make it look like you have wings on your back, if that makes sense. And I think for those of you who can do that, you know what I'm talking about. Another way to understand if you have it or not is if you have the ability to put your hand up against the wall and then push your body forward. Does your scapula jut all the way backwards? Is maybe another way to test it. But what this tells us is there's instability. We don't have a lot of good suction from the scapula to the thoracic spine. And that over time can create instability and ultimately cause shoulder pain as well. So that, again, how to change it, how to fix it, making sure you do isometric holds, scars, those kinds of things. But ultimately, you need to know you have the issue first. How do you do that? Go see a provider. If you are having shoulder pain, hip pain, these are things that we can make a difference with. Now let's talk about the hip, because I don't think we've given the hip a little bit. We've given the shoulder a lot of attention in today's pod, but let's end with some good things for the hips. Doc, let's just, before we start with protocol, most of the time when we talk hip now, we're talking the more anterior lateral pain hip here. When patients have a lot more posterior hip, they're maybe thinking more SI joint. And so we just want to make sure we delineate between the two. But when patients are having hip pain here, what are some maybe few tissues, few areas that you start thinking about how to improve? And what are some gems that you bring to the patient, usually more commonly right away, to help them?
Well stated. I would first look at with hips, pelvic floor, and does the ball and socket joint, move different from the lower back? Meaning, when you're going to assessment, if you rotate your femur inwards or your foot out, are you able to move that different from your lower back or different from your hip hiking upwards? If they move together, there's a lot of tightness guarding, and you want to break apart those two. So that would be the first place I'd start. Practitioner, like you said, is very important to differentiate those two, chiropractor, physical therapists. DO to a certain extent. There's some good practitioners out there that maybe didn't say that have those licenses, but those would be the first things I would look at specifically. And then you would want to see, okay, if there's pain with the hip, ball and socket movement, is it open, close angle pain? That would also differentiate in terms of, is it a capsule issue or is it a ligament tension, more of a neurological issue? So you can differentiate between that a little bit. But I think the biggest tool for most people, other than cars, workspaces, moving the hip through the base range of motion, would be the position 90-90, to where it almost, if you would think about sitting crisscross applesauce, but keeping one leg and then rotating the other one behind you, that would be a first that you can open up and start increasing internal and external range of motion of the hip itself. And then there's different progressions to where you would hold yourself up for periods of time and then try to lift your leg or feet up, whether it's your front foot or back foot up, to stimulate all that tissue tension into the capsule and the small rotators of the hip itself.
Beautiful. Yeah.
Doc, is there any that you can think of? And then or if you want to touch on pelvic floor,
I would say patient comes to me with true hip pain. I'm thinking of 4 different things, and I include these in all of my assessments. I'm going to be thinking hip flexor, because I know a lot of patients sit a long time and they get this kind of ache into the anterior hips themselves. And so I want to test, is it tight? Is it weak? Do I need to stimulate it? Do I need to improve range of motion? Is it the joint itself that's causing overlying tightness? These are all things that I break down. The other 3 are going to be the TFL IT band, the glute medius, and then at certain times, certain adductors, gracilis, those other things too. What I'm testing is really the internal hip, the anterior hip, the lateral hip, and the posterior hip. And I'm trying to see, is there restrictions and movements with any of those areas, or is there weakness with any of those tissues? And weakness doesn't always mean it's atrophied. It just means, we talk motor units, it just means it's not being, there's no facilitation and there's not a lot of recruitment. So over time, as you sit for long periods of time, that neurological stimulation will decrease and you're going to lose motor recruitment, your involvement. And so the things you used to be able to, you might not be able to do it long, or it's more painful. So really what I'm thinking about is breaking the hip down into different sections. Can you move into good range of motions in each of those sections? And is there weakness or deconditioning with each of those areas? And then I'm doing exactly what Doc's been talking about. We're doing CARs or joint work for any of those areas. And then I'm doing overlying either neurological rehab for those tissues. And then I'm teaching patients how to eventually do that themselves. A good one that I think most patients that I have them do right away, that Doc has shown, is where they bring their hip or their leg all the way outstretched and they're going above, but then they're doing some rotation along with it, similar to the shoulder. That's one that I think is helpful to add some extra value and effort. And then I'm having them, usually most patients have really tight hip flexors. I'm having them bring their leg off behind the table if they're lying down on their back, just letting it hang for a little bit. But then I have them push up into their hand for at least 30 seconds and then try to also stretch that back. That resistance can be helpful as well as the hip extension part of it too, to help stretch that hip flexor. But that's 70% of it in a nutshell. There's obviously a lot more that we do that it's tough to break down just in 20 seconds. But I think most of the time, when you understand the foundation of what Doc is talking about, that is going to translate into any joint, most joints. Some joints are a little bit different, but most joints that you have issues with, this foundation works. And if you can understand working the joint first, then adding in isometric holds, then starting to get into the things that you want to do in the gym, that's where you're going to have much better effort and better load tolerance.
Yeah, stated. I don't think I could add any more onto that. If you guys do want to go more in depth, there's a bunch of other small things in some of the other videos that we've touched on in terms of hips, shoulders as well. But yeah, Doc, really well stated. I think there's a few quotes that we want to leave the listeners to remember and to remind themselves that. I'll start with the first one. Movement is sculpted by force, and force is the language your cells listen to.
Love that.
So more or less thinking like if you're going to a stretch, you're going to need force or a muscle contraction at that stretch, specifically for the body to be able to move in that range of motion more comfortably.
Yep. I love it. That was a good one.
Doc.
Longevity is earned through controlled movement, not just stretching. Again, that's just what you had stated, where passive stretching now really has, and I think Doc and I have differing opinions on this, because Doc likes to say that, yes, passive stretching has its play, but I don't remember last time I passive stretched, just because I find it to be a waste of time. Now, certain times, yes, some patients can get benefit with it, but it's so short term that I'm just not even adding it into my patients' homework at home. They're doing dynamic movements, they're doing resisted loading, and they're just doing things that I think move the needle a lot quicker.
Yeah. There's that nervous system communication, brain to tissues. If you don't have that, then it goes back to the point the doc said, you'll have it for a period of time, then you'll lose it. Or you get a massage, you'll feel pretty darn good for maybe a day, couple days, maybe a week, and then it comes right back, or the tension, tightness does. It's that communication between the two that your brain cortex needs to be able to facilitate to the external structure of yourself.
Yep. And then motion is lotion, train or to lose it. We know that's going to be something that over time, if you aren't, you're going to be losing, I think, what is it? 1% of speed is lost every year after, or power, 1% of power is lost every year after age 30 or something like that.
Something like that.
Yeah.
1 or 2%, and then it compounds at the age of 60.
Yep.
There's another drop off incredibly well from there. But
Yeah, I understand not a lot of you want to play competitive sports anymore, and so you don't feel like that's important. But once we get to, like Doc said, 60, where it starts to get even worse, that compounding starts to pull you away from even doing day-to-day things that you would love to have explosive power for.
Yeah.
And you maybe you don't know what we're talking about yet because we haven't got there, but explosion to get up off of the floor can be even a difficult effort for some people that they've lost. And you're like, why has that gotten so bad? Did you train it? And if you said no, I am sorry that you haven't, because we don't want you to get to that point. We really don't. We don't want you to have to be a turtle on your back and you can't get up when you're at a certain age. We really don't want that. Independence is everything, and we want to make you feel comfortable and confident.
Stated with everything there, Doc.
Yeah.
Love that.
Alrighty. Everyone, that was the capsule joints. We're talking hips and shoulders. Thank you so much for listening. This is valuable. Please share. We want to make sure we educate and just keep everyone filled with value. That's what we do, why we do what we do. Anyway, Doc, anything else?
Well stated.
Perfect. You guys have a good rest of the week. We'll see you soon.
Disclaimer, the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.